Greetings and welcome to today's webinar on viral load in pregnancy and the postpartum period. My name is Jennifer Pearson and I'm a technical advisor on the AIDS-Free project. Before we begin today's presentations, I'd like to quickly review the Adobe Connect environment and set a few norms for today's webinar. Today's webinar has 3 presentations followed by a discussion period during which our speakers will address your questions. Within the webinar environment, please make use of the Q&A box on the bottom right side of your screen to share your thoughts, note your questions, or ask for help with sound during the presentation. Questions that you ask are only visible to you, our presenters, and technical support. If you are experiencing difficulties, our technical support will respond to your question privately. We will collect your questions for our speakers and will save them for the discussion period. It's great that we are able to connect people from so many places today, but your experience may vary based on your internet connection and computer equipment. I will briefly go over a few troubleshooting steps if you have technology challenges today. A few tips. If you lose connectivity or cannot hear at any time, please close the webinar. Re-enter the meeting room in a browser other than Google Chrome by clicking on the webinar link provided. Use the Q&A box to ask AIDS-Free Tech for assistance. But if these troubleshooting steps are not successful, please rest assured that the webinar is being recorded and you will receive an email with a link to the recording following today's event. The recording will also be posted on the AIDS-Free website. Questions that don't get answered during the Q&A sessions today will be compiled after the webinar, shared with our presenters, and responses from them will be shared with all participants and others via the AIDS-Free website. To get us started, I will now turn it over to our moderator, David Sullivan.
Thanks, Jennifer. I would like to welcome and thank everyone for joining us today. My name is David Sullivan. I am an HIV and AIDS Clinical Services Advisor here at USAID Washington in the Pediatric and Maternal Branch. And I will be assisted by my colleague, Jeff Quechcotot, throughout the presentation. For today's webinar organized by AIDS-Free, we've invited 2 really excellent speakers to discuss their experience and lessons learned in viral load testing in pregnant and breastfeeding women. The first is an overview of the Kabeho study in Rwanda, including trends in maternal viral suppression and adherence over the 2-year postpartum period, and subsequently a review of maternal viral load monitoring and retention in urban and peri-urban antenatal clinics in Johannesburg by colleagues from ANOVA. And before we transition to the country presentations, JJ and I would like to provide somewhat of an overview of this field of viral load testing in pregnant and breastfeeding women. I'll go to my presentation. My computer just fell asleep. Sorry about that. And I'll begin on slide number 2. The first thing I'll say is that some of you may be new to these AIDS-Free webinars. Some of you, I welcome you back. It's really a pleasure here at USAID to work with the AIDS-Free team on these things. And I call to your attention here on slide 2 the address for AIDS-Free as well as the recent sequence of sessions and discussions on viral load in general, ranging from back in March 2017, tools for scaling up viral load monitoring, followed by some technology tools supporting scale-up, managing viral load results. We will touch a bit on that today as well. Most recently, improving early infant diagnosis. You may be wondering, well, gee, David, these sound great. Where do I get them? Please refer to the slide that you see, the link that you see, pardon me, at the end of that page. So moving on to page 3 of this webinar, as I mentioned, we'll have 2 excellent presentations by colleagues whose work took place both in South Africa and in Rwanda. I'll thank them now and at other moments during the presentation, but we're grateful for their time and their expertise in moving this important field and important work forward. So I'll begin with some discussions that many of you, clinicians, program people, others working in the field, and elsewhere know well, measuring viral load in pregnancy and the breastfeeding period can be particularly difficult. We're going to talk about some of the considerations around that statement. You're going to hear me for the next 14 slides or so talk around some of the current state of affairs with guidelines for viral load assessment during pregnancy and the subsequent breastfeeding period, when people are testing, where they're testing. The where is usually occurring at antenatal clinics. However, some of you are thinking, well, gee, David, the breastfeeding period is so long. How do we do that and where? All the answers are not there. It's one of the reasons we have our colleagues with their work in Rwanda and South Africa to help us. And I welcome discussion and suggestions from the audience today. The other component we'll hear about, obtaining viral load results, what to do with them. There is a dyad to consider both the mother and the child. And then my colleague JJ will talk a bit around some of the research we've looked at our desk review here at USAID and with the assistance of colleagues at AIDS-Free. Moving on to the next slide, talking about guidelines. So as you may recall, some earlier AIDS-Free webinars talked about some of the guidelines with viral load monitoring. I will reiterate things that were said on previous discussions, that the WHO guidelines as of 2016 didn't have exact language around the pregnant woman. The adult woman was treated similar whether pregnant or not. The 6-monthly period followed by 12 months thereafter. So nothing exact regarding pregnant women in the WHO guidelines, although we all may know that currently WHO is discussing guidelines, or recently did back in May, so we can anticipate some new guidelines coming soon. Well, I will say that the WHO guidelines did mention the other important member of the dyad, namely the infant. I call your attention to the red arrow and the fine print at the bottom here of slide 7. The high-risk infant may need different attention to his or her low-risk exposed peer. In particular, and I'll draw your attention, please, to that small print. High-risk infants are defined as women who have received less than 4 weeks of ART at the time of delivery. That number will come back later in my presentation, so thanks for remembering it in advance. Women born to women with established infection with a high viral load, that was also going to come back. And born to women during the diagnosed during the pregnancy or breastfeeding period. What do you do with these high-risk infants? Again, I know some of you have a lot of expertise in this regard, but there is advanced and more lengthy prophylaxis that is offered. You're going to hear about that in some of the guidelines coming up. The slide 8 talks about the standard all-adult guideline. The right-hand side of the screen shows what you do if that mother has been shown to be taking her medicine yet to still have a persistently elevated viral load. You're going to change her to second line. I remember doing that in my own experience with patients. I'm a pediatrician, so it's more with the kids, but never an easy proposition. A happier result is you counsel the mother and retest her, and shows that actually she's resuppressed. That's a more pleasant outcome to often a difficult scenario. So slide 8, some of the text is missing. Apologies, guys. This is the Kenya guidelines, and there'll be a PDF sent out around this. But the Kenya national guidelines, hey, look at that. That's cool. The Kenya guidelines, great, show that there is advice for women on ART versus those who have newly initiated. And there is a viral load schedule during the breastfeeding period mentioned in these guidelines. So you have, I'll just go through the language in case it is difficult for you to see. For pregnant and breastfeeding women, this is the 4th bullet point. women newly initiated obtain viral load 6 months after initiation, reminiscent of the WHO guidelines, and repeat the viral load after 1 month, and if still greater than 1,000, you're going to change to a different regimen. That's different than the WHO guidelines. If less than 1,000 copies, repeat every 6 months until the end of breastfeeding. And the final bullet point, I'll call your attention to the public health approach the nation of Kenya has taken. All exposed infants are going to get 12 weeks of prophylaxis. It's not high risk or not, or otherwise, but important to consider as you look at that exposed infant and each nation's individual response. Slide 10 is the South African 2015 viral load recommendations in pregnant and breastfeeding women. 6 monthly if the woman is suppressed. If she is not suppressed, you have a similar version to the Kenya guidelines, and you're going to consider changing to the second line regimen. I'm in that box that says greater than 1,000 copies. And any woman who has a second line therapy switch, that woman's going to receive the appropriate counseling and assistance given the difficulties of taking second line. Slide 11, I'll call your attention to the red arrows, talks about the extended prophylaxis offered to infants who are high risk, namely maternal viral load suppression is elevated. Women who are HIV negative need to have, this is the first arrow, repeat HIV testing, and also during breastfeeding. This is important because, as the room may know, in the early weeks of infection, your viral load is high. This could be a risk to passing of the child. JJ is going to talk a little more about some of the studies we've discovered regarding the fragility of the breastfeeding and pregnant period for women with HIV. So thanks for your attention during those that quick guideline review. I'm now moving through the red slide 12 onto slide 13, which is the importance of viral load testing in pregnancy and breastfeeding women. Nachega and colleagues talked about, this is a 2012 study, so predates some of the guidelines that we've discussed, but in a foresighted way. Research studies have found adherence to ART during pregnancy often to be suboptimal. It's a difficult period for the woman and for the family, in particular if you have a chronic illness. It is important, as you can see with the second bullet point, to diagnose HIV promptly and initiate ART to reduce the risk of mother-to-child transmission. And the postpartum period is particularly fragile. You need to follow them up because they may become viremic. And the timing of when to do viral load is important. This is a discussion I hope that will ensue after after the presentations today to see when how to respond to that viral load result. Mother's prognosis and the determined prophylaxis regimen for the infant, as discussed in the Kenyan and South African settings just a moment ago. Slide 14. This is a study out of Malawi. Haas and colleagues showed that women who started ART under option B+, less likely to adhere appropriately than those who were not pregnant. So that is going to be your solid line, which curves to the bottom, and then the hash, not the dots. It's a little bit of a tricky chart. One of the reasons we'll share these presentations so you can look at them and digest at your leisure. But what we should know is that just finding a woman, putting her on ART is not the end of the story by any means. Slide 15, there's viral load for women initiating ART in pregnancy versus those conceiving already on ART. This is a discussion that has even come up in the, we'll say, medication realm with dolutegravir. That's not a discussion for today, but the woman who started ART before pregnancy is a different individual than one who starts during pregnancy. There is a higher rate of mother-to-child transmission for the women who start during pregnancy. And Hoffman and colleagues noted that each additional week of ART, the viral load is coming down and the mother-to-child transmission risk is decreasing. In addition, Chibwesha, apologies if I mispronounced that name, pregnant women who have been on ART for less than 4 weeks, please remember the earlier WHO guidelines and risky infant descriptions, are 5.2 times more likely to get that virus to their infants. And early and sustained control of viral load is associated with decreasing risk. That is your mother who's been on ART for longer than just that gestation period. On to slide 16. This is the sort of good news, I guess, left side, not the right side of that viral load algorithm we talked about under the guidelines a few moments ago. If the viral load is suppressed, there certainly are ways in these therapeutic moments to make life a little more comfortable for that woman, demonstrating good control of her chronic illness. In particular, there is differentiated service delivery. There are links at the bottom of this page that you can see for recent WHO conferences about this. Mothers may have synchronous appointments with family members that are less frequent than the typical ANC. They offer families health services under one roof. Mothers to Mothers is an excellent group to offer support to the field, to the patient, pardon me. So that's the good news side of the story. If the viral load is elevated, and I will say thank you now, and then at the end of the presentation, Landon Meyer was really helpful in presenting this slide, and I tip my cap to him and his team and the work they're doing advancing the field. If the viral load is elevated, that is an urgent moment. There's a time-limited period to reduce transmission risk from conception through delivery and breastfeeding. These transmissions occur late in pregnancy, perhaps when the woman got infected during gestation, during delivery, and the postpartum period. Bullet point number, the third bullet point, excuse me, the objective is to achieve viral suppression before delivery and maintain it during breastfeeding, however long that lasts. If the viral load is elevated, I've now moved to slide 18. The Landon Meyer and colleagues suggested that the routine WHO algorithms may not be enough. And I remind you of what the South Africans and Kenyans are doing, just as two examples. Protease inhibitor, second-line therapy, not always easy to give. I've mentioned that above, but an important thing to consider as the patient, regardless of her gravidity, is failing first line. There is an opportunity to enhance infant prophylaxis, mentioned above in guidelines, if that mother is unable to get her viral load down, and more frequent viral load testing as gestation winds down and even into the breastfeeding period may help you assess who's highest at risk. And I did mention the stable viral load less than 1,000 mother. If the viral load is greater than 1,000, there are also things you can do to reach out to that woman. There are mothers to mothers can help that person. There are more frequent visits. Many things that some of you may know, and that I hope will also be part of our discussion. What do you do to help that woman with a high viral load when she is pregnant or breastfeeding? So now we've reached the end of my session. I will defer to JJ, who's going to take you through some of our depth review. I'm going to silence my thing and let JJ talk.
Thank you very much, David and Jennifer, and it's a pleasure to be here today. As David had mentioned, my name is Chapkwech JJ Kotut, and I work with David at USAID on the pediatric and maternal branch. I'll be walking you through the research and current programming considerations. So I recognize the slides are text heavy, but I will highlight the main points as we go through the slides. On slide 20, the median time for HIV seroconversion was 32.8 weeks gestation. And women who tend to seroconvert later in pregnancy had a high chance of transmitting HIV to their babies compared to women with known HIV status. On to slide 21. Pregnant women have a high chance of contracting HIV in late pregnancy and postpartum compared to women who are not pregnant. This is while adjusting for condom use, age, use of PrEP, HIV viral load. slide 22. As many of you know and work in African settings, breast milk is a key survival strategy. However, poor ART adherence for HIV-positive mothers is a challenge in those settings. So it is important to use a combination of strategies, such as extra support to mothers on ART so that they can be adherent, and include some of the maternal, neonatal, and child health interventions, such as the maternal and child health vaccines. And overall, these two strategies, among many others, will improve the maternal and child health outcomes in these settings. In slide 23, so this is a South African study, and 30% of postpartum women who were previously virally suppressed experienced viremic episodes at 12 months. So it gives us the characteristics of mothers who are more likely to have viremic episodes, and they tend to be young mothers and who are previously exposed to ARVs, and women and mothers who started off with a high viral load pre-ART. So on slide 24, this talks about switching regimens during pregnancy, and it was found that it does not destabilize viral suppression. In fact, it's better for a pregnant woman to switch her regimen because it improves her virological control after the switch compared to women who do not switch their regimens during pregnancy. So on slide 25, in summary, it gives us a profile of a woman who is more likely to have virological failure, and this is a young mother and a woman who had not disclosed her HIV status, and those two were more likely to be non-adherent to ART and may or may not have depression, which has also been associated with poor adherence. So on slide 26, so this one summarizes the factors associated with maternal to child transmission of HIV, and it also gives us a similar characteristics of mothers who tend to have high virological failure, and these are young mothers who are less than 19 because they tend to have unsuppressed viral loads, and mothers who weren't exclusively breastfeeding their babies. On slide 27, in this South African study, postpartum women who were initially virally suppressed were likely to be viremic within a year post-delivery. So the solution to this in the paper was intensive viral load monitoring, especially for postpartum women, because they tend to have high viral load and tend to be non-adherent. So that 28 is a continuation of that study. On slide 29, in this simulation study, it was talking about what are some of the timings in which we can take a viral load for a pregnant mother, and it found that taking viral load in concurrent with the gestational age was a better timing compared to taking the viral load based on when the woman initiated ART. On slide 30, it just talks about women who tend to have a high viral load, and it's usually postpartum women. Slide 21, it further gives an explanation of women who are most likely to have MTCT, and these are women who started ART in the second and third trimester, and women who were non-adherent at some point on the ART regimen. Our final slide gives questions and considerations that our programming should factor in when they are considering about programs focusing on clinical, behavioral, and health systems research in their settings. So thank you very much, and thank you very much for participating today. Please add your questions in the Q&A box for our discussion period, and please silence your phones and devices. I'd like to introduce our first speaker, Michelle Gill, who's a Senior Research Officer with Elizabeth Glazier Pediatric AIDS Foundation, ECPAF, and was a co-investigator on the Kigali antiretroviral and breastfeeding assessment for the elimination of HIV or the Cabejo study, which will be presented today. Thank you.
Thanks, JJ. Good morning and good afternoon, everyone. Thanks for the opportunity to present with you all today. As she said, I'll be presenting on the Cabejo study, which stands for the Kigali Antiretroviral and Breastfeeding Assessment for the Elimination of HIV. The study was supported by USAID and represents a collaborative effort among the Rwanda Ministry of Health, EGPAF, and others. So you can see the list of PIs and co-investigators, and I'll be presenting today on behalf of this team. The primary aim of this study was to evaluate the overall 18 and 24-month HIV-free survival in Rwanda's Option B Plus PMTCT program in a cohort of around 600 HIV-positive pregnant and postpartum women and their infants in Kigali, Rwanda. Women were enrolled in the third trimester of pregnancy or within 2 weeks post-delivery. And the study began enrollment in 2013. Mothers and infants were followed through 24 months, and the last visit was completed in May 2016. The study also determined birth outcomes, including stillbirths, prematurity, low birth weight, and gross congenital anomalies, nutritional outcomes defined as stunting, underweight, or wasting, and adherence to ARVs among pregnant and postpartum women and their HIV-exposed children. This was a facility-based prospective cohort taking place in 14 high-volume facilities in an urban area. I just wanted to give a little bit of background on the testing that was done as part of this study. Blood samples for maternal viral load were collected at enrollment, around delivery, at 18 months postpartum, and 24 months, and tested using RNA-PCR. We defined undetectability as less than 20 copies per mil, which is the lower limit of detection with the lab assay. For EID, DNA PCR testing was conducted at birth and around 6 weeks. And while the blood samples were collected within 2 weeks of delivery, birth testing was actually done retrospectively, and serology testing was done at 9, 18, and 24 months. And any positive PCR results were confirmed by a second test. So both maternal viral load and EID had their samples processed at the National Reference Lab in Kigali, and the PCR testing was conducted using Roche Cobas AmpliPrep quantitative and qualitative tests. So this slide presents the distribution of viral load results at enrollment into the study, stratified by time on ART. And again, enrollment for this study was either in the third trimester or by 2 weeks postpartum. And at that enrollment visit, we asked about their time on ART thus far. So if they were newly diagnosed or newly initiated on ART and ANC, they were likely categorized in that 0 to 4 months on ART. And overall, median time on ART of our study population was 13.4 months. And we found shorter ART duration was associated with higher viral load, which is not necessarily surprising. And this blue bar shows the less than 20 copies. And as you can see here on the left, women who were on ART for 4 or fewer months had the lowest rate of undetectable viral load at 30%. And if you look at those middle 3 bars, over 70% of women on ART between 4 and 36 months had undetectable viral load. However, we start to see an increase in detectable viral load for those on ART greater than 36 months, with that bar on the right. So using the standard definition of viral suppression, less than 1,000 copies captured on the orange bar of this graph, in total 85% of women had a result of 1,000 copies or less versus around 52% with less than 20 copies. And finally, as you can see from just the note at the bottom, among women who had a viral load test at 24 months postpartum, 78% were undetectable and 91% were virally suppressed. However, this was only available for 70% of our original sample, and I'll talk about that a little bit more as we end the presentation. So at enrollment, we looked at predictors of detectable viral load by logistic regression using generalized estimating equation, and found that women were more likely to have detectable viral load if they had no education, side effects, and an ART duration of less than 4 months, and that's compared to women on ART for either 3 or more years or 1 to 2 years. And also just to note, adherence was not a significant predictor of detectable viral load in our model. However, I should say that adherence was measured through 3-day refall, which is a fairly limited measurement of adherence. So this graphic shows the follow-up of women and infants over the 2 years of the study, aligned with time points for HIV testing. And on that left side, you can see that's the child retention. And on the right are the numbers of children who were terminated due to death, transfer out of a study site, or whose caregivers withdrew their consent. Other infants who were expected at these time points but did not return for any further study visits were considered lost to follow-up. So really the takeaway here is in this urban population, in a country like Rwanda, we still had quite a bit of drop-off, about 76% of kids remaining by the study endpoint. And in total, there were 67 mother-infant pairs who were lost to follow-up, and 51 withdrew from the study or transferred care. So maternal retention was around 75 to 80% as well. And this table depicts HIV infection, death, and HIV-free survival at birth, 6 weeks, 9 months, 18, and 24 months. Just a few things to note. I know there's a lot on this slide, but there were a total of 26 infant deaths, and that brought us to an estimated 24-month infant mortality rate of 4.8. In terms of infection, there were 2 children infected at birth, determined by retrospective birth testing. One was found to be infected at 6 weeks, and the other had a subsequent positive and then 2 negative tests before a final positive test at 9 months of age. There were 0 infections at 18 months and 1 at 24 months, for a total of 6 infected infants, and just to note that all of whom were quickly initiated on ART. If you look down there at the bottom where those red circles are, we had calculated a Kaplan-Meier cumulative probability of HIV-free survival. And as you can see, that survival at 24 months is 93.2 and a transmission rate of 2.2%. So I also wanted to include some qualitative data from in-depth interviews that were conducted with a subset of the 600 women. So in total for this piece, we interviewed 112 women. And we divided them equally among women who had children at these following ages. So women who had children who were 0 to 6 months, 7 to 12, 13 to 18, or 21 to 24 months of age. And what we found through our thematic analysis is that there was a trend towards poor adherence around the time of breastfeeding cessation, so when that child is no longer exposed to HIV. And mothers of children at 13 to 18 months were least often virally suppressed and had been on ART the longest, though I should caution that this was a small sample size and not possible to do any kind of statistical testing around this. Women in this, with children in this age group also reported the fewest number of factors facilitating their adherence and reported inhibiting factors to their adherence more frequently than mothers of children 0 to 6 and 7 to 12 months of age. And finally, fewer women with children 21 to 24 months indicated that they were comfortable with lifelong ART compared to mothers with children at other ages. So some conclusions and lessons learned. There was low HIV transmission and high HIV-free survival rates that could be achieved with the national PMTCT programs in breastfeeding populations. And this study actually represents among the highest survival rates that had been reported in a real-world clinic setting in these breastfeeding populations. However, loss of follow-up of HIV-positive women and their exposed infants within the CMTCT program during the 2-year postpartum period significantly affects the accuracy of survival rates and the determination of a final HIV status in the child. It highlights the importance of continuity of care in mobile populations, even when women were all receiving care in Kigali, which is a mostly urban setting. And thirdly, the study showed high rates of viral suppression in women in PMTCT programs. But as we saw on the earlier slide, there's that uptick in viral load, and vigilance is needed for those on ART for longer durations. And as with survival, suppression was high for those who showed up to the clinic and were tested, but we simply don't have data for around a quarter of the women in this sample. And finally, more attention is needed to ensure results of viral load testing are appropriately integrated into PMTCT. Clinical consultations and suspected treatment failure can be more swiftly addressed in pregnant women. So this gets at some of the issues that David and JJ were highlighting, and I'm happy to talk a bit more about that in the discussion. So thank you very much for your attention. I've included links to the relevant articles, which include the findings highlighted here today, and I'm happy to take questions at the end, or my email is there if questions come up later. I'll now turn the presentation back over to our moderator, David.
Michelle, that's great. Thank you very much. A lot of food for thought, some exciting protection for mothers as you described in these PMTCT programs, but also important not to take our eyes off the ball. As a reminder, please add your questions for Michelle in the Q&A box for our discussion. Everyone's doing a great job muting their phones. I think you're one of the best audiences I've ever had on a webinar, so hats off. And our next presentation is from colleagues in South Africa, Diana Nazipo from Anova Health Institute. Thank you, guys.
Thank you, David. Hello, good day, good morning, good afternoon to everybody on the webinar. I'm Diana Mokoena, and I'll be doing the first half of the presentation, and then I'll hand over to Nozipo Masekwa, who will do the remainder. And we will be talking today about our experiences with maternal viral load monitoring in the antenatal clinics that we support in the Johannesburg district. So first and foremost, a bit of context in terms of the HIV care and treatment program in the country. So we work in South Africa, that's highlighted in green on the map on the top right of your screen there. And in our country, there's an estimated 7 million people living with HIV, which is nearly 20% of the population. Among the pregnant women living with HIV, over 95% of them are accessing care and treatment or prophylaxis to prevent transmission of HIV to their children. But despite this, we had, in the 2016 UNAIDS GAP report, we had an estimated 12,000 children who were newly infected with HIV due to mother-to-child transmission. Also of note is that among the people living with HIV in the program in the country, less than half of them had a suppressed viral load on routine monitoring. And then just a bit of context in terms of the province where we work currently as Anova Health Institute. We work in the Gauteng province, and annually there's nearly 100,000 births from the different public health facilities across the province, and the HIV prevalence rate at antenatal clinic is still sitting between 20 and 25%. So ANOVA is a district supporting partner that is funded by USAID, and we support the city of Joburg. It is the biggest metro in the country, and if you look at the map of South Africa that's in red there towards the top right of the screen, Joburg is a metro within the blue. The blue is the Gauteng province. You can see geographically, size-wise, it is the smallest out of the 9 provinces, but population-wise, it is one of the biggest in the country. So the city of Joburg in total has nearly 5 million people living there, and I've highlighted on the map of the city of Joburg in the center of the slide with the red stars, the regions where ANOVA currently supports. So out of the entire metro, we support about 65% of the population in the city of Joburg. That's a total of 80 public health facilities, 4 of whom are hospitals. And currently we have just over 200,000 people that are enrolled in the ART program in these clinics. We provide support for care and treatment for both adults and children. A lot of activities around PMCCT, or prevention of mother-to-child transmission, integrating TB and HIV care. We also support the health information systems, mainly the DHIS and the TIA.net, which is an electronic database that we use in the country for monitoring care and treatment for patients on ART. We also do some work around supporting pharmacy and supply chain management for both medication and commodities related to HIV and TB care. I won't spend too much time on this slide because David already covered it in his introductory presentation. But in 2015, our guidelines for management of HIV were updated, and what was new is an additional sort of schedule in terms of viral load monitoring for pregnant women specifically. So what you'll see on the bottom left of your screen is the current viral load monitoring for the general non-pregnant population. You'll see that we don't do a viral load on diagnosis. The first viral load you will get 6 months after starting treatment. If that viral load is suppressed, your next one will be 12 months thereafter, and annually if the viral load remains suppressed. What's different for pregnant women is at entry into antenatal care, you will have 2 main groups of women. So you will have women who are already known with HIV and are already started on ART, and if they've been on treatment for at least 3 months, they will get a baseline viral load. You will also get a second group of women who are newly diagnosed with HIV at ANC. Those women will not get a baseline viral load, but would get their first viral load 3 months after starting treatment. Thereafter, your second viral load will be done 6 months after a woman has been on ART, and 6 monthly thereafter until the cessation of the period. So despite this enhanced viral load monitoring being built into the guidelines, we are finding that in practice the coverage of viral load monitoring or uptake remains poor in pregnant and breastfeeding women as a population. So this slide shows a comparison that we did with routine data that's collected through TIA.net. So we looked at obviously the 6-month viral load uptake. So on the left, the bars on the left of the graph are showing in blue is the number of patients who were eligible for a 6-month viral load test in the general population. And you'll see that that's nearly 9,000 people. Only 38% of those actually had a viral load done, which was captured on TIA.net. And of those who had a viral load done, nearly 90% of them had a suppressed viral load. If you move to the 3 bars to the right of the graph, it shows us that there was 1,441 pregnant women who were eligible for a 6-month viral load test, and nearly 60% of them had a viral load done. The suppression for those who had a viral load done was 87%. So from this graph, we can already see that viral load uptake tends to be higher in pregnant women with HIV compared to the general population. But of great concern for us is that over a third of these pregnant women who have HIV, who were eligible to have a viral load test done, did not get one done. And that means that the potential risk for mother-to-child transmission then remains high. In the quality improvement project that we undertook, that Nozipho will be sharing a bit more about in a few minutes, we focused on viral load uptake at the 3-month visit and not necessarily on the 6-month monitoring visit. Just a bit more about what we do as an organization in supporting the PMCCT program. As a district supporting partner, we are responsible for providing technical assistance to 80 out of the 123 facilities currently in the city of Joburg. And our main goal in the activities that we do is to increase access to diagnosis, to treatment, and monitoring for all people who are living with HIV. In order to improve, to meet these objectives for pregnant and breastfeeding women living with HIV specifically, we conduct quite regular trainings on these 2015 guidelines followed by mentorship. And that's mainly because there's quite a high rotation of staff between the antenatal service point and the delivery unit, as well as shift work that happens. So in addition to capacity building that we do for the staff, both the clinical staff and the non-clinical staff looking after these patients, we also do a lot in terms of demand creation from a patient perspective. So we do a lot of awareness and education for patients through one-on-one sessions using lay counselors and mentor mothers, but we also do a lot of health talks in the waiting areas of the different service points at clinic level. So on the right of the slide, you will see some of the tools and material that we've developed as part of this technical assistance that we're giving around viral load monitoring overall. You will see that the bright red T-shirt there, and the front and the back is identical. The T-shirt says, "Are you on ARVs? Ask for a viral load test at your clinic." And this is a T-shirt that's worn by both ANOVA staff and Department of Health staff. It's often your non-clinical staff who are the ones who usually walk around from service point to service point, interact with patients at in waiting areas and the like, and they generally serve the purpose of generating a buzz around viral load monitoring, because when people see people in the staff in these bright red T-shirts, they're interested to know what it is about, what is a viral load, etc. Next to the T-shirt is a poster that we use at facility level and other venues outside of clinic. And the poster says, "Are you on ARVs? Ask for a viral load blood test at your clinic." There's a patient-level pamphlet, which has the exact same cover. And inside the pamphlet, it gives more information on what is a viral load, when is it done, what is the importance of it, what do the results mean, etc. And lastly, sort of behind the pamphlet and the T-shirt is a tool that's targeted at clinicians. So it's a viral load collection sort of calendar that clinicians can use to remind them when a viral load is due. Apologies, it doesn't seem to be projecting that well, but you'll see that on the left it's got the calendar months of the year from January to December, and then horizontally, if you follow each month horizontally, it says if this woman's antenatal booking visit was in January, then the first viral load is due in April, the second one in July, the third one in January, and so on and so forth. So despite that the guidelines were updated in 2015, and the fact that our mother-to-child transmission still remains quite well below the 1.4% threshold that we're using in the country in terms of monitoring transmission. What we found is that the 3-month viral load uptake was generally quite low. And even though mother-to-child transmission is sitting at around 0.8% in Johannesburg and Gauteng as a province at the moment, that still means an average of nearly 500 babies that are being born with HIV, when this could have been prevented with more stricter monitoring. So we decided, the other thing I wanted to add is, as an organization, we don't try to implement everything everywhere at the same scale. So we work on a focus for impact model. So out of the 80 facilities that we support, we identified 10 that we classified as high impact. And those were mostly facilities that had delivery units. So therefore the number of women who are pregnant and accessing postnatal care is higher. It's also facilities that generally had higher numbers of women accessing antenatal services before delivery. So we identified 10 of these facilities who had a viral load completion at 3 months at less than 90%. Together, Nozipo as a PMCCT technical advisor for the ANOVA team, together with the rest of our technical team, nurse mentors, quality improvement advisors, then conducted root cause analysis at each of these 10 facilities to identify what were the contributing factors to the low uptake that we were seeing. Following the root cause analysis process, then an intervention would be selected based on what we identified as a cause. If it's an issue of clinicians not understanding guidelines or not knowing recent guidelines, then training would be used as an intervention, followed by mentorship. After implementing the intervention that's specific to the root cause, we then monitor the viral load uptake for each cohort on a monthly basis. And once we have implemented these QI activities, we then have regular feedback with the facility, where we would sit down with the facility manager and the clinicians working in the antenatal service point and go through, when we started, you were only doing viral load tests for 10% of the women who should have had a viral load. Since our intervention, we are now sitting at 30% up, for example. But in the next few slides, then Nozipo will take you through more detail of some of what we found as causes in the root cause analysis, as well as the results of the QI project overall.
She mentioned earlier on the root cause analysis that we're doing. You will note in the slide some of the findings that we found on the facility level. Like you said before, sometimes it will be knowledge where you will train the staff. Sometimes on the patient side also, you would note that if there's no understanding, earlier on David mentioned something around if patients are not adherent, you will find probably poor outcomes. And in some facilities, like, challenges are not the same. It might be the systems. If they don't have enough staff, you will find that they might push the medication and don't do some of the things that are meant to be done. If the filing system is not so great, there's no access at times to the physical file, then you find a clinician just giving the medication without proper assessing where the patient is due for viral load. And also other factors will be looking at also the counselors that we are working with. We will sit in at times, note what is the quality of counseling, and then if there's any gaps that we identify in the staff, we'll ensure that we'll train them. Also, when the staff in completion of the clinical notes, you will find that at times, if the visits are not written nicely, the next person who sees the patient, if they don't check clearly, they won't note that the patient is due for a viral load. And also a huge factor that we're seeing in Johannesburg is that some of the patients just default. Now, we live in a very high mobile community. This is an urban setting. Everybody's here for work. So there's that tendency that people move around because they rent, they move here, they move here. And then also earlier on, Diana mentioned the interventions. I think she has talked through most of the things that are in the slide, your T-shirt, the calendar, and some IEC material. One other thing that we also do for the clinician, if we note in the clinic that the clinicians do forget to do the viral load, we do some stickers. It's basically a sticker that is written viral load due, that you would audit the files, probably go through a cohort, you note that this cohort is due for a viral load, you staple, you put that sticker in so that the next person, clinician who sees that patient, they don't miss doing that viral load. And we have seen this really becomes very helpful. Just to share also some current activities, because sometimes when you do things alone, it gets a bit heavier. So we have roped in some of the clinics that we identified as poor performing mental mothers. Those are lay counselors that have been through the PMTC program that are there in some of the clinics to work with them because they are there on a daily basis. So what normally happens is the PMTCTA will generate a list on a monthly basis. So this we are doing on a month-to-month, because in the past what we did was we will go and check maybe the previous month who was due for a viral load, how many did we manage to do, and we noted that we were always running behind. So what we do now is on that current month, we give the list to the mental mothers. When they receive the list, they go through the list at the beginning of the month. They pull out all the files with the assistance of the data capturers. We go through the files, each file, to see if the patient is still active in care. If we know that the patient has missed a visit or so, we haven't seen the patient recently, we start the tracing, calling, and making a follow-up on that patient, hoping that on that current month, the patient might come back. And then during that month, then as the patients are coming in, those that we have noted that are due, will ensure, the mental mothers will ensure that the patients are done. And then at the end of each month, we'll do then a summary to see from the 10, for example, that we had thought, that we noted that are due, how many did come? And from that 10, how many did we do? And then what are the results? Have we ensured that they are in the file? Have we ensured that they are captured on here? And then also just to share, in the few clinics where we are currently doing this, you might note we have clinics, like I said earlier on, we're hoping everyone, it will be at an uptake of about 90% with but surprisingly, the clinics that is really not that great. I'm not going to go through all of them, but you might note just the first clinic, the uptake before the QI, they were at 10%. With this little activity, generating the list on a monthly basis, putting the stickers, they moved to about 46%. So you would note as the clinics. But message just to note today is that with more focus, things really move. Just in conclusion, what we had noted is that 6 months overload completion is higher than 3 months overload than in the general population that Diana had shared. And then, yes, we have seen our transmission rate has remained low. And then also that overload completion at 3 months can be improved through QI methods. And then also that we need capacity building for non-clinical staff because they play a very valuable role in that quantum of care. And then we're hoping to continue these QI interventions, hoping that all our clinics might move to above 90 in the uptake, also to support those champions that we have in the facilities, and probably to let another group of high-impact facilities to focus on in the near future. And yeah, we'd like to thank USAID, Department of Health, especially the Gauteng province and the Johannesburg Metro that we're working with, and also the ANOVA team that, yeah, we're out there trying to do our best for the patient. Thank you so much. I'll hand over to
Diana. Thank you. Oh, yeah. Thank you, Diana and Deepa. That's a great presentation, a really interesting look into a multifaceted effort to sort of transfer this knowledge and recommendations. I was struck by that site with the before and after, as you pointed out, some places better than others. It's exciting sort of portrait of a QI project that's ongoing. So we're now going to use the rest of our time together, and thank you everyone for staying with us. It's a pleasure to be here with you. Please type your questions for the presenters in the Q&A box on our screen. We'll try to get to as many as we can in the time remaining, which is about half an hour if we need it. Any questions that are not answered will be collected, and we'll ask speakers to share their responses and post them on our website. The links, you may remember, were on some of my earlier slides at the talk. And I would extend that to the sort of community of professionals out doing the work, as Zifo mentioned, in the field with the patients and the men and women at offices like where JJ and I are sitting here in DC. So we're all together in this. Great to be able to share knowledge. So let's go to our first question. I think Jennifer is going to read the first so you don't get too tired of my New York accent, and then JJ and I will get to others.
Great, thanks, David, and please do continue to add your questions. Our first question today is from Dr. Modi Dumo, and he asks, and I'm going to direct this to David and JJ related to guidance, regarding conducting a viral load testing on a monthly basis for pregnant and breastfeeding women who started ART during pregnancy and had their first viral load after 6 months on ART. Is this a new WHO recommendation, or is it based on research?
It's an excellent question. The WHO guidelines are not too specific for pregnant women just yet. I think there is research as presented by colleagues working in Rwanda or work in South Africa or JJ that favor more frequent assessing. However, I would say that it is still the standard 6 monthly after diagnosis and then yearly. The guideline group met just this past month in Geneva, if memory serves, and I, like the rest of the room, is probably, I'm waiting for their additional guidance. But apologies if I did not make that clear during my earlier presentation, but it's still pretty similar, the non-pregnant adult female and the pregnant adult female. But as I hope has become clearer to all of us, the pregnant female needs different attention.
Great, thank you so much.
In the interest of efficiency, Jen, I can answer the second one if you like. I can read it and answer it if that's efficient.
Please go ahead.
Claudio Muserere asked a question about dolutegravir. I'll weigh in, but I would love to hear what others on the phone or colleagues are experiencing. It's a really hot button issue. My computer is smoking here in my office as I think about it. So WHO had a call to the field and some stakeholder community organizations last week, if memory serves. Current guidance is kind of a wait and see. Women who are on dolutegravir before pregnancy is discovered need to have that discussion with their provider. Women who are, because the research, a few cases out of Botswana found some neural tube defects in infants, 4. Those who are on ART and have not yet switched to dolutegravir should stay on, and those who are starting ART and cannot guarantee contraception if they don't intend to have babies, effective contraception, should consider not being on dolutegravir. At the risk of repeating myself, there are guidelines coming out later this month from WHO. We're all very interested in our various offices and practice settings. But it's a hot button issue. Let's see. I will ask a question and then you can stop hearing me. This is for our colleagues in South Africa. George Ikarahoa asks, I observed long turnaround time was not included in your fishbone analysis. Does this mean that your chosen facilities had PCR lab in situ? So thanks, Anova, for any wisdom you can share with us.
Thanks for the question, George. Is this turnaround time for viral load results? I'm assuming, David?
Yeah,
Is the
so
section-
in the fishbone analysis, it was noted that turnaround time, I guess, was not cited as a challenge. And the question follows, does that mean your chosen facilities had a PCR lab in situ?
No. So currently, all the facilities that we chose for the QI and the rest of the facilities that we support don't have a PCR lab on site. Viral load specimens are sent through to the National Health Laboratory service for processing. But in terms of turnaround time, that is not as big a challenge as the challenges that we had listed in the root cause analysis. So on average, it takes, I think, about a week to get a viral load result back. And clinics get both a hard copy of the results, but they're also able to log onto a results portal on the NHLS system and access results using a PC or even a mobile phone. I hope that answers that question.
Thank you, Diana. And the next question is for you again, and this question comes from Florence. Do pregnant women pay for viral load testing? User fee has been a major problem having our patients do the viral load as requested.
For the question, definitely no, they don't pay. Our public patients don't pay when they come to access care in our primary health care clinics. They do not pay. Thank you.
Thank you. David, your next question?
Let's see. So, thank you very much, Jen. So it's that we see no other questions on our chat box, but the AIDS-free team and JJ and I have been thinking of some questions for both of our presenters and also for those attending if they have things to say. I'll start with, so one of the early questions we had, any thoughts on the recommended frequency for viral load testing? We wondered if it should be synchronized with ANC visits in a way, or the trimesters, with vaccination visits as an effective use of the mother-child health platform. I'd love to hear our presenters' thoughts on what they think is the best timing and frequency. I recognize we are all somewhat beholden to guidelines, but as we navigate this, it'd be great to hear both Michelle and Diana and Nazifo's opinions. Thanks, guys.
This is Michelle. I can start. Personally, I think what we're seeing still in some of these lifelong ART programs that, women are still coming in at various stages. Some are newly being diagnosed with HIV. Some will just be starting on ART. And I think having, separate viral load monitoring schedules, I think, makes sense, particularly as we're, talking in this era of differentiated care. I think one of the issues that, we found, particularly given these varying stages of, length on ART, time of diagnosis, is the issue that, while we're still combining pregnant women and adults for viral load monitoring in Rwanda, as far as I know, really this becomes an issue, particularly when you're starting to get those who have treatment failure. So Rwanda guidelines currently have additional adherence counseling and referral for clinical consultation if you have a viral load of greater than 1,000 copies on 2 tests. But these are at 3-month intervals. So, the extent to which viral load is managed per guidelines, you really do need these special considerations for pregnant women who may be delivering before that second test, and really trying to see, how can we kind of better target, intervention for women who are experiencing high viral load before delivery. So I think the current guidelines just don't reflect that same level of urgency that's needed for a pregnant population.
It's Diana. I think just to add.
Thank you, Michelle.
I think just to add on what Michelle just said, I think from my perspective, it makes sense to have a different sort of schedule for women who were already who fall pregnant while on ART and those who are newly diagnosed. For those reasons that were spelled out in your presentation, David. I think another factor where I think the earlier viral load monitoring makes sense for us in South Africa specifically also is something that we didn't really go into detail in our presentation on, but quite a number of our pregnant women come for antenatal care quite late in their pregnancy. So if we're only going to have your first viral load monitoring test 6 months, for example, after initiation, you're not going to find most of those women still in care in your antenatal service points. So I think for us, it really makes sense that you've got that 3 months post-initiation of viral load monitoring, so at least you know where you are before delivery, hopefully, in terms of reaching viral suppression. David, I was struggling a little bit to type this question in, but JJ had mentioned a study that was done in South Africa that was looking at viral load monitoring by gestation as opposed to how long you've been on ART. Are you able to tell us a bit more about that?
Thank you, Diana, for the question. So it's a simulation study, so they did not use actual patients. They're just seeing how one would be the advisable stage of taking viral load measures for pregnant women. And the study found better, so they recommended it would be advisable to measure viral load for pregnant women at A and C visits, so at the first trimester, second and third trimester, as opposed to measuring viral load when the woman started ART. So if that's what the study was.
Okay. All right. Thanks.
Great. Thank you. So our next participant question is for Michelle. Was there an attempt made to locate lost to follow-up mothers? I'm sorry, I was just going off mute. We did make an attempt. However, we were conscious that this was an observational cohort study, so we first wanted to utilize the existing system for tracking and tracing patients who are lost to follow-up using community outreach workers and things like that. So we did kind of let those systems play a role first before intervening, but still we simply just had some people that we could not locate again.
Great. I'll continue. This is David again. Additional questions that we had been looking at. So Marcy Levy asks, regarding Rwanda and Michelle's presentation, any theories about why a mother's adherence may have dropped when the child was 13 to 17 months old? I was wondering that too. It was an interesting point you made during the presentation. And as to why mothers of 21 to 24 months, probably at the end of their breastfeeding periods, were less likely with lifelong ART than other mothers. That's a question for Michelle, although I would be interested to hear after Michelle finishes what the South African colleagues feel about the periods of good or bad adherence that they're observing with their pregnant and postpartum moms. But thanks, Michelle, for your thoughts on adherence in the 13 to 17 month period and why the mothers of 21 to 24 months were less comfortable with lifelong ART than other mothers.
Thanks, David. I think it's more, this is what our data were showing us, and I think, we can, speculate for one that those women who had children at 13 to 18 months, there may have been, some sense of, okay, my baby is healthy, it's around the time of breastfeeding cessation, potentially have had that final determination of HIV status, and maybe there's less of a motivating factor. As we know, women are highly motivated to adhere to a PMTCT cascade for the sake of their children, and once that child may be healthy or seemingly so, it might be, there might be some kind of drop off there. Excuse me. The other thing that's not listed here is that there are, we captured as part of our quarterly interviews with these women any life events that may be coming up that may have affected their adherence, such as, a loss of a job or a loss of a family member. And these, there was a slight increase in those types of life events among this age group, which could just be a coincidence, but with the small sample and the qualitative data collection, it wasn't possible for us to figure out if that was really more the link to this as opposed to something related to PMTCT. And again, I can only speculate about why women with children at these older ages might be, experiencing might not be comfortable with lifelong ART. I think there's probably more here to explore as PMTCT programs mature. It could be, a sense of fatigue with taking treatment. Again, once you have this healthy 2-year-old child, you might kind of shift your thoughts on treatment elsewhere. So that's certainly, a possibility. Though again, it's a small sample size, and I think something that we could dig into a little more.
Okay. Thanks. Any thoughts about South African colleagues on the, yeah.
All right. From our side in Johannesburg, what we were currently also looking at that, and what we have picked is that the picture on our side, we are more likely, when we put women on treatment, the first 3 months, it's very critical because we seem to lose a lot of them. And what we have seen is that if they survive and before 5 months on treatment, they are more likely to stay in care for years. But the first 3 months, we have noted that we seem to lose them a lot. Hence, these QIs that we're currently busy with, we are really also looking at the quality of counseling and also ensuring that there's support for these women, especially in the beginning stages. And also, like I mentioned, that they are late bookers. If really the message is not so laid clearly in the beginning, they are prone that we're going to lose them. So we are trying strategies to ensure that when we put them in care, there's extensive counseling that is ongoing so that we really keep them in care. Thank you.
Thank you, Diana. Thank you, Michelle. Our next question is again for both presenters. Was there any use of mobile interventions in addressing loss to follow-up for mothers? We can start maybe with you, Diana.
Hi, thanks, Jennifer. In our QI project specifically, we're not currently using any mobile apps specifically, but in terms of tracing those patients that may have missed an appointment for both viral load monitoring or antenatal care services, we usually trace them telephonically. And as I said earlier, we use the care.net system, which is an electronic database, to generate the list of the cohort and the patients tracking and tracing. But there aren't any specific mHealth tools that we are using at the moment.
This is Michelle. We did not use any kind of mobile intervention for our study.
Okay. Thanks, everyone. These are excellent questions. And at the risk of repeating myself, this is not meant to be a one-and-done question session. I think we'll continue for the next 10 minutes or so. It's a lively conversation. But also going forward, we are all each other's resources to continue investigating this. Some of the questions we had been preparing in advance on our end included, we were wondering what programs are doing to address clinical and psychosocial needs for the woman who tests pregnant during pregnancy, at delivery, or while breastfeeding in the postpartum period. It'd be interesting to hear. Sounds as though ANOVA has a lot of pretty sophisticated messaging getting out there. But we'd love to hear both from our ANOVA and Cabejo colleagues if they had thoughts on the messaging to those two populations. I think, as we have been discussing, one group has a potentially higher risk, assuming those who are on ART longer term are actually taking their meds. So I'd love to hear about your messaging to the women at the time of their diagnoses. Thanks.
Hi, it's Diana again from the ANOVA team. So on our end, just adding on to what Nozipo was saying earlier, we are really finding that the women who are newly diagnosed with HIV during pregnancy or delivery, as you said, David, are the ones who are at most risk for poor retention, and at times they do not suppress the viral load adequately to prevent transmission to their babies. So at the moment, what's currently available is a lot around IACT. I don't know if the people on this webinar are familiar with IACT, but it's a modular sort of structured program where that focuses on adherence and disclosure support. And that's what we are currently implementing with the help of the mentor mothers and some of the trained lay counselors. So newly diagnosed pregnant women would then be enrolled into an IACT group, almost like an adherence/support group. And it's a lot around conversations around the diagnosis, the support, the journey that they will walk through in the PMTCT program. It's the type of program that you can tailor make for different groups of patients. And when we're dealing with pregnant women, we do try to tailor it specifically around the PMTCT journey that the mental mothers are very familiar with. Yeah, I think that's what, in terms of what we're currently doing, we do have some ideas and discussions that we've been having internally in terms of what else is needed for that psychosocial support that you were talking about, David, because we do recognize this group of newly diagnosed women to be quite at high risk of dropping off and poor adherence in that first 100 days. Thanks.
And I can just say from my side, this is Michelle again, that, you know, in that qualitative assessment that we did, you know, as Diana was saying, in terms of that early and newly diagnosed phase, that's really the time, just those first few weeks or months when you're starting, we noticed women really struggled. Again, some women were coming into our program had already been on ART, but for those who were coming into the PMTCT program pregnant and starting on ART, there was, you know, a greater experience of side effects. You know, they needed help in terms of absorbing the shock of being HIV positive and starting on treatment, and across the board had said being linked to other women through support groups or some kind of mentor mother situation really was one of the best things that could happen to them in terms of feeling like they're not alone and really giving them support for times where it seemed really hard to stick with their drugs and to adhere to them. So that came out strongly in terms of that first phase. But there's less information, I think, on how we are supporting women again through the postpartum period. Again, it's quite long, that time that they're breastfeeding. In our Rwanda population, we had women who, at the end of our study endpoint, so 25, 26 months, and there were still a handful of women who were still breastfeeding. So really just to identify that for a woman's own health and, being aware that some of those babies are still exposed at that point, how do we better support those postpartum women during that extended period and, after delivery and cessation of breastfeeding for some, and really to, support them to not only do what they need for their children, but also to make sure they are remaining healthy. I think we probably need to, focus a bit more on that phase, just because it is so long and it does fall, after the, delivery and potentially the end of breastfeeding.
Great. So thank you for everyone's answers to the questions, for your participation, and for your time. As we approach the end of our 90 minutes together this morning or afternoon, I'll say thank you, and then colleagues from AIDS-Free will also say thank you. But great that we can be in a group setting like this to talk, even though we can't see each other's faces, to continue to support each other as we gather more information, learn more things about how to protect mothers and their infants during this period. It's sort of more and more complex the more one looks at it, but I think the lesson of Mothers to Mothers, as we just learned, is if one can feel supported and in a group that's looking after you, your outcomes are better. So let's model that for ourselves as well as for the families we serve. I will turn the floor back to our AIDS-Free colleagues, but please know that we here in DC are grateful for the work that you are all doing. It's a pleasure to participate in this with you, and I look forward to crossing paths in person or on the phone with all of you soon. So I'm still on the phone, but I'm turning it back to AIDS-Free. Thanks, everyone.
Thank you, David. Before we wrap up, we would just like to take a moment to thank all of the speakers for sharing their time and expertise today, and for all of you participants for attending and for this rich discussion. As I mentioned at the beginning, in a few days, you will be receiving an email with a link to today's webinar recording. And before we sign off, I do want to encourage you to take a moment and to fill out the poll questions you're seeing on your screen now, as this feedback really helps us to improve future webinars and to determine what topics are of interest for future webinars. I'd also like to really encourage you to visit the AIDS-Free Viral Load and Early Infant Diagnosis Knowledge Base and to sign up on the AIDS-Free website to receive monthly updates. We are continually adding new resources to the knowledge base, and we really encourage you to share with us the guidance and tools that you're using to guide scale-up of viral load testing, as well as early infant diagnosis for inclusion in the site. So thank you all once again, and have a great rest of your day.